the conversation needs to happen now, because the face of that in general practice is changing, and women can and will be heard if they assert themselves and advocate for themselves well enough. And I think that's why podcasts like this, your podcast and everything from A to V, all of them, really aim to empower the patient. So, when they're coming to the GP, they know the right questions to ask. They know to come with a diary and all of those things that are going to really help to get the message across.
Welcome to episode 2 of Endo Untangled. My name is Dr. Alicia Macro. I am a general practitioner, and I have with me my lovely co-host, Cherie Noble, who is an accredited exercise physiologist.
Hi, everyone.
And we're here to welcome one of our colleagues, a wonderful women's health GP, Dr. Sneha Wadhwani, hailing from Sydney today. And we're looking forward to hearing a little bit about her and some of her insights. Today, what we're hoping to cover is what we call pelvic pain as a super syndrome. So one of the things that we see so much is women and people struggling with pelvic pain without finding clear answers and a clear pathway forward. And our call to action today is really about perhaps we need to all just take a little step back and look at the big picture so we're not missing the forest for the trees.
Yeah, as we were talking about that zoom in, zoom out concept. And so today we're zooming out a little bit to look at the whole system. And as you mentioned, patients coming in with loads of different symptoms, thinking that they may have different conditions happening when it's really all connected and potentially part of one syndrome.
So we're here to welcome my colleague, Dr. Sneha Wadhwani. Dr. Sneha is Good morning. Dr. Sneha is a credentialed GP specialising in women's health who emigrated from the UK in 2015. She co-founded Evoca Women's Health, a national GP network under 4Health, which launched in 2022 and now includes 35 clinics, including 2 government-funded endometriosis and pelvic pain clinics.
That's impressive.
She is impressive. As national clinical director, she leads Evoca's 120 plus women's health GPs, nurses and allied health providers. She also oversees clinical governance and service delivery across 39 4Health medical centres in New South Wales and ACT, and leads GP wellbeing initiatives. A New South Wales conjoint lecturer and GP supervisor, Sneha has also co-created the podcast Everything from A to V to debunk women's health myths. Sneha, welcome.
Welcome.
Thanks for having me.
We are so thrilled to have you here. Sneha, you and I have our paths have crossed through the work that we do, but I would love to actually hear a little bit more about you as an individual. So you've been with us in Australia for a few years now, and quite frankly, been quite an overachiever, overshadowing the rest of us quite significantly. But I'd love to hear how did your pathway lead you to Australia, and what made you interested in women's health?
Okay, that's quite a big question, isn't it? I'll try and keep it brief. I guess I've always loved obs and gynae. So when I was a med student, I think I did my elective in the West Indies on this tiny little island, and saw obs and gynae in the most raw rural form and loved it there. And so it was kind of something I always wanted to do. Unfortunately, I was diagnosed with a chronic health problem, which meant that, the prospect of specialist training, on calls, night shifts, surgical rotations was just probably not going to be the right decision for me. And so I opted for general practice, but also embraced the fact that, GPs are quite special. We're innovative thinkers. We are problem solvers. And I love that part of what we do in general practice, which is really quite different to what happens in hospital medicine. So that's what took me to general practice. And I sort of flexed my muscles a bit in the kind of women's health space over in the UK. I used to work alongside a gynecologist in outpatients and did lots of other things in different obs and gynae specialties along the way. But ultimately, I left the UK because of the NHS, unfortunately. No work-life balance. I think your wings are definitely clipped in the UK as a practitioner, specifically as a GP, not wanting to make the impact and create change in the way that we can here in Australia. So, and definitely wanted to be around more for my beautiful daughters. So came over to Australia about 10 years ago now. It's 10 years in March, which is super exciting. And started to, I guess, dip my fingers in to the space, and yeah, quite overwhelmed and surprised at how well it's done. So that's my journey and why I'm here. But ultimately, you know, I think as a woman, you know, we all know Jed Carney and various other people have spoken about it, but there's a lot of medical misogyny out there. Women are unheard, dismissed, suffering in silence. It's a huge cost to the economy. It's a huge cost to personal, physical, psychological, and social health. So I want to make a change. And I think that's what we're all doing here. So hats off to you too, Alicia. You do some pretty amazing stuff too.
Oh, thank you. And Cherie, who we've just been talking about her video production skills, which are on YouTube. So we can talk a bit about that later if we get time.
Well, and I think you've already addressed the next question that we had, which is why this conversation matters. I mean, you've really hit on some of the big pointers there, but I guess for our listeners in particular, like, why does this conversation matter?
Unfortunately, whilst there is greater awareness now around endometriosis and pelvic pain, you know, thanks to the highlighting of this topic through government, you know, that has raised the profile. There's still a lot of doctors out there who don't feel confident in the space. I hasten to use the word lack of knowledge or understanding, but I think it's actually they just don't have the confidence to try treatments, to make a diagnosis without a specialist involved. And really that comes from a historical legacy of being told, you know, laparoscopy is the gold standard, you know, so GPs think that, the patients think that, and without that specialist involvement and operation, patients may often think they're getting shortchanged. But what that often leads to is because the GPs don't feel empowered and they don't feel confident, they'll either dismiss the symptoms or not be able to put them together, as you were talking about when we started this. You know, often these patients will have multiple symptoms that on the face of it seem unrelated, but actually you need to have confidence and feel, you know, assured in what you know to be able to pull those symptoms together and feel okay that you're not missing anything awful, you know. So I think it's a confidence thing in the GP space. And I think for the public, you know, it's probably many years of feeling dismissed and unheard. But I guess what I would say is that the conversation needs to happen now because the face of that in general practice is changing, you know. And women can and will be heard if they assert themselves and advocate for themselves well enough. And I think that's why podcasts like this, your podcast and everything from A to V, all of them, you know, really aim to empower the patient. So, you know, when they're coming to the GP, they know the right questions to ask. They know to come with a diary and all of those things that are going to really help to get the message across.
Mm. So I guess, Sneha, just to backtrack a little bit, I thought perhaps it might be helpful to just flesh out a little bit about what we mean as a super syndrome, particularly in terms of endometriosis and pelvic pain. And with me, what I have come to recognise more and more, and as a GP, we work in pattern recognition. That's our work.
Yeah.
Is I feel like the more I see, the more strongly the patterns show themselves. It's almost like the magic eye drawings from the 1990s that you can't see it until you can, and then you can't unsee it. And so I'm interested on your thoughts, Sneha, but just to sort of, from my perspective, I think about and talk about quite a lot the concept of a cranky pelvis. So if you've got a cranky pelvis, you have a cranky uterus with painful, heavy periods often. You have almost always a cranky pelvic floor structure, which spasm and causes pain. It always causes a cranky bowel too. I don't think I've met many women with pelvic pain who don't have bloating, constipation, diarrhea, discomfort, trouble with bowel pain, trouble with going to the toilet. They often have difficulty with bladder. They often have difficulty with vulva, and they often have knock-on effects that affect the rest of their body. And again, I think our colleagues GPs are amazing at dealing with individually each of those problems. And I think if we can achieve helping our colleagues, GPs, physios, EPs, dietitians, to actually put those little dots together, there will be so much improvement for the patients. And our patients, once they can start understanding the links between these different problems as a big picture problem, it helps them move forward as well.
That's right, yeah.
I hope I'm not alone, Sneha. Do you see the same picture that I see in your practice?
I do. I think what's interesting is that many women feel that if their pain isn't related to their periods but is in the pelvic area, then it can't be endo, therefore it's not pelvic pain, therefore maybe it's my bowels. So they also end up going down that road, which a lot of GPs still do. You're absolutely right. But I think the important thing to recognize is that pelvic pain is more than just pain in the pelvis, and it's certainly more than pain coming from the uterus or the tubes and all that kind of, the women's health organs, really. So I think we need to really pay attention to the fact that when pain is cyclical, that's usually a reasonable indicator that the uterus is cranky and there might be something around endo or adenomyosis, something like that. However, when pain is becoming more regular and it's occurring on a sort of more daily basis, that's when we get this central pain sensitization. And that's often when we get whole body symptoms, the sort of mental health, the fatigue, all of those things as well. And it's because the nerves in the pelvis have basically fired up the whole central nervous system. And I think what patients need to understand is once you've got to that point, actually that's when it's difficult to treat. But actually, if we can preempt that, so if you're having regular pelvic pain, then you need to be seeing your doctor, if this is more than just a one-off, because we don't want you to get to that sensitization, point at which things start to get a lot worse. So absolutely, I agree with you. I think it's important to recognize that, constipation in childhood can trigger a chronic pelvic pain syndrome. It doesn't need to be, I had my first ever awful period, it can be something completely, or what's seemingly completely unrelated that then becomes related. So I think it's vice versa. It's both sides of that coin. And the other shout out I think that's really important here is the statistics in terms of, number of women who've experienced sexual violence is really, really high. And sexual violence alone can be a trigger for chronic pelvic pain. So, I think we need to look at not just pathology in terms of, the medical problems that are going on, but the environmental and psychosocial components as well that will sensitize these nerves and give women these symptoms.
It's so refreshing to hear from medical professionals this whole person approach that I feel is talked about a lot, but from what we're hearing from people, it's not often what they're experiencing when they do visit medical professionals. Seeing that person in front of you and zooming out and taking the whole picture is, I guess, very validating and, taking in all of the information to inform your decision-making and what this person's care needs to look like.
Yeah, I think it's a challenge that we face. It was amazing to hear about your story, and certainly the NHS's loss is our gain, Sneha. And look, I think in general practice we have in many ways a wonderful health system here in Australia, but it's not without its challenges. And one of the challenges we have is time constraints. from the legacy of the health system that we've inherited, which wasn't designed for someone to come in with the unbelievable complexity of what we see with pelvic pain.
Yeah.
And since we've been having our endometriosis clinic where I spend an hour with a patient for their first visit and always go over, and even an hour and a half is not enough to cover what we'd like to cover. The healing that can happen just from having space to share your story in a non-judgmental way with understanding and empathy helps so much. And there is so much to be gained from a treatment point of view from understanding the whole story. But for a woman or someone assigned female at birth with these symptoms, they've spent years trying to have that conversation and be heard in that way. And I think I'm hopeful that there'll be more medicine practice like this in the future.
Yeah, I think, with the funded endometriosis pelvic pain clinics, we are afforded a little bit of luxury in that space. We have extra resources, like you've got your wonderful, exercise physiologists, pelvic floor physio, psychologists, dietitians. We can employ all these people to support that service. And that's not always the case in normal general practice. Now, if we just rely on those endo pelvic pain clinics, we're not going to reach enough patients in this space. But I work with our Evoker teams across the country, and to really try and empower them with, look, in that first consultation, what we want to do is make the patient feel heard and validated. Yes, an hour and a half would be wonderful, but we can still do that in a 20-30 minute consult. And in that space, really demonstrating a commitment to go on the journey with them is very important. So, you might not be able to sort this patient out in 1 or 2 appointments, but at least telling them and educating them that, we're going to go on a journey together. There's going to be a few appointments that we're going to do along this process. And I might need to see you 6 or 7 times before we get to a place where you are actually, you've got your treatment plan in place. We're using all the allied health options that will support that as well. And you are really seeing some demonstrable improvements in your pain scores and your quality of life scores. But what you're saying to them is, yes, I can't magic this overnight, but what I can do is take you on a journey and make it better for you in the long term. It's a bit like, when you do a weight loss journey with a patient, you're going to do it gradually and in increments, so that it's sustainable long term. And this is similar in that way. We don't want to throw a whole heap of everything at that person who's already overwhelmed, stressed, feeling sometimes a lot of blame themselves. They're blaming themselves. They're feeling guilty. What haven't I done? What am I eating that's wrong? I might have put on a few extra kilos and that's making it worse. Or, I've put off having children because of this and now I'm worried about my fertility. So there is a component where they believe some of it is self-inflicted. And because it's misunderstood or dismissed, they also have that dialogue that it's in my head. So I think when we can give them, if we try and give them too much in one go, it's all too big a change in the context of a life that is already really difficult and being led around the pain, controlled by the pain. So I think, that stepwise approach, yes, it's a longer journey, but, being able to do that with the patient is a nicer way of building rapport and trust, but also, creating those long-term sustainable outcomes.
I must admit, I hear not infrequently the fear that people have before, if they do go to have an ultrasound or an MRI or a laparoscopy, what if they don't find endo? Could I be making this up? Is it me? Am I putting it? It's just like they get really stuck in this place. And I hope that from sharing these stories through this podcast, people can start to also be able to zoom out the way that we are describing, to understand, because of the complexity of what happens and how there can be a number of different triggers that start this this process in motion that leads to the same group of symptoms, I can put my hand on my heart and say to my patients, if there's not endometriosis found on your scan or at your laparoscopy, you've still got the same symptoms. You still deserve to have your symptoms validated and treated just like anybody else. And it is the same pain. We know that because we see it over and over. Yes, endometriosis can be part of the picture that leads to the development of this problem, but so can, as you say, chronic constipation, sexual violence, not feeling safe, being neurodivergent, recurrent urinary tract infections, pelvic infections, recurrent surgery, so many things. Endometriosis is one part of a big picture.
And I think the question I often ask my patients is, I let them tell their story. And then I say to them, okay, well, there are features of this, and there are features of this, and there are features of that. And some of those features might be endometriosis. But overall, you've got a chronic pelvic pain picture. Now, there are various different approaches to how we might work out what's causing what in this space and which parts of your pain are coming from what pathology. And that might include a laparoscopy. It might. But I'll ask you this question, and this is what I say to my patients. A laparoscopy won't necessarily cure your pain. If there's endometriosis there and it's amenable to treatment, it may reduce your symptoms for a while, but it's not the be-all and end-all. And the next time you have a laparoscopy, it may be a bit less effective. And the time after that, it will be even less effective. And what's more, every time you go in there and have an operation, it is a trigger for this pelvic pain syndrome anyway. So when you put that to patients, or when I put that to patients, I say, is that the avenue you want to go down? Because a lot of them have that agenda already there. And when they say they want to avoid that, that's when I say to them, okay, well, what is the harm in trying some of these treatments to see, actually, can we improve your symptoms without going down that route? Because in reality, if there is menstrual related pain, whether it is endometriosis or not, and yes, there are certain caveats to this, but broadly speaking, does it matter? Our treatment can be entirely the same, The only missing piece is the laparoscopy, which even if it's endo, doesn't need to be our first line approach anyway, and probably shouldn't be. So I think, the concept of pelvic pain with or without endometriosis doesn't mean that pelvic pain doesn't exist if you don't have endo, and it doesn't mean you can't use the same treatments. And in many cases, I would argue, does it matter at this stage,
Do you find that your patients are responsive to that, Sneha?
Yeah. When you take the time to sit and explain to them, there are, sometimes we just need a laparoscopy. If I've given you 600 treatments, hopefully not 600, but you get my drift. If I've given you lots of different treatments and we're not getting anywhere, then maybe we need it at that point, no problem. I think the amazing and impactful Professor Susan Evans says you get one laparoscopy.
Why do you think we're so hung up on the laparoscopy?
Because I think obs and gynae was inherently a surgical, it's a surgical specialty, isn't it, really? And the medicalization of the field has evolved over many years. And, there's been an absence of primary care based or non-surgical guidelines that actually make sense, and are actually applicable to general practice. So, GPs are very strongly evidence-based practitioners generally. And so in that space, what you'll find is they'll refer to guidelines that say laparoscopy is the gold standard. That's how we've all grown up, in this space. And so, I think that's where it's come from. But, we are really lucky to have now. Actually, are we lucky? Should this not just be the case anyway? That's a whole different conversation. But more and more gynecologists are coming into the space going, actually, this needs to be with general practice. You know, Susan Evans is a fantastic advocate for that. So is Jason Chow. So is Professor Thierry Van Kai. You know, there's so many of them in that space who really want to help to empower GPs in that space and encourage patients to go back to their GPs for this kind of non-surgical and very holistic management. Because let's be honest, hospital gynae outpatients are fantastic, but they can't do what we can do in general practice, in the community, around our patients, in terms of, you know, the allied health care provision and that ongoing support and care that that whole team will offer, you know.
Yeah, we often talk about scaffolding.
Yes, absolutely.
Can you talk us through that a little bit, Sheree? What you mean by that?
Well, I guess it's more along the lines of what we were talking about, and what I wanted to pick up on with you, Sneh, as well, is that it can feel very overwhelming. You know, they've never been heard, they've been dismissed, there's so much going on. It's so overwhelming. And even when you are acknowledged with the symptoms and what you're going through, that can be overwhelming and emotional in itself. And we know that this is a complex problem which requires multiple practitioners at times to, you know, assist with different areas of their specialty in collaboration. And when you then, the next step is, okay, we're going to see the pelvic physio, and there's exercise physiology, and there's, you know, a number of different lifestyle and foundation. I would think sort of foundational treatments that we can, and management that we try before we go to some of these surgical, you know, interventions. But that's a lot in itself. So it's like, let's build the foundation first. Like and, you know, that's where GPs and yourself and practitioners like Alicia are so good at being able to, I guess, triage in a sense. Like, what's our first priority? What's our foundation that we can build the foundation for your care plan? And then we're going to scaffold around that, so that then the next step after we've built the foundation, okay, this is like the next level that we're going to address to support you on this journey to health and well-being.
Absolutely. And I think we've got to be sensitive with how we give that messaging. So we know that if you've got pain in your pelvis, your pelvic floor muscles and your obturator internus are going to tighten up, right? But what we don't want to give in terms of messaging to the patient is, you've got this problem with pelvic pain and now you've got a problem with your pelvic floor muscles. So instead of coming out with that one diagnosis, they've come out with 5, you know, because that's a burden to carry as well. So I think, as Alicia said at the beginning, part of our role is helping the patient to connect the dots and connecting the dots for them. So that helps, I think, to reduce the overwhelm, because what you're doing in that process is basically saying, you've got 15 problems on your list, but actually we can link all of those to this particular issue. And actually that means we've just got one issue to sort out. Yes, we're going to tackle it in different ways, and it's going to mean some different approaches for different things, but we're dealing with the same problem together. So I think you're absolutely right. The overwhelm is important to acknowledge, and the scaffolding around it is really essential in helping them with that. The other component that I think is really important that scaffolding really addresses is the concept that, you know, when you have your diagnosis of chronic pelvic pain and we've given you a package of care, you know, these patients are hopeful for a cure, right? That's what they want. But we know that the reality is that's not going to happen. We can make them a lot better. But this is a pelvis that is easily sensitized. This is a pelvis that can be triggered by all sorts of things, and stress can be one of those things, you know. So we need to prepare them, much like we do for other chronic conditions such as eczema and asthma, that these are your trigger points, and actually at some point it will flare up again. Now, hopefully it will never get to where it's been for the last however many years that have taken you to get help, but you know, we'll help you create a plan that you know how to escalate and de-escalate so that you are empowered to care for this long term. And when you need that extra support, you can actually come back to us and dip into more care. So the scaffolding works, yes, to improve the sense of overwhelm or reduce the sense of overwhelm around the diagnosis and the commencement of treatment, but also I think long term in managing those triggers and flares so that they don't, you know, exponentially evolve in a adverse way.
Yeah. I heard recently the analogy that recovering from any sort of pelvic pain, any kind of persistent pain is going to look a little bit like a Toblerone bar. So it's a bumpy road and we need to expect that. So we improve and we're going to have a little bit of a backward step sometimes. We improve again and there'll be a backward step. And that's so important to point out because I've seen a lot of progress made with different people that I've worked with, and then something will happen and they'll have a setback, which can feel catastrophic. And if it's not planned for, it can be catastrophic. I've seen people go a long way backwards who thought that it was better. And I've been better for 3 months now. I've had 10 years of pain, but the last 3 months have been good. So I've dropped that thing that I was doing and that thing because I don't need it anymore. And then it comes back or there's something that happens. So I'm hopeful that we can fund Toblerone bars in our practice drawers full just to show there's a tax benefit from that, and snacks as well are good.
Yeah. Absolutely.
Sneha, what I'm hoping to cover with the time that we've got left is I prepared a couple of slides for some talks that I've given to politicians. Cherie and I presented to a South Australian select parliamentary committee into endometriosis, and we popped together some slides in a very stressful way the day before we presented.
That's how we roll.
Which is when the best work happens, the best creative work, because I'm a real visual person. I think a lot in pictures, and I want to share pictures with people, but I feel like the pictures that I want to share don't exist. And so in moments of pressure, I have created some pictures. So those who are watching on YouTube will be able to see these, but it's probably not a bad thing, Sneha, that you can't see them because it means I have to describe them well enough for people listening as well. So
this is going to be fun.
So I've got 2 slides, and for those who are interested, we'll pop them in the show notes. So I've got a slide which is initiators of pelvic pain, and I've got a slide which is perpetuators of pelvic pain. And I show this to a lot of patients when I see them at the first visit. And my initiators of pelvic pain analogy is a funnel. So at the funnel, there's about 3 rows of different conditions, which mixed together, come out the bottom of the funnel as persistent pelvic pain. And the point I try to make with people is what we've already covered today, is that there's not one thing that tips you into the sort of symptoms that you have: the severe constipation, the bloating, the headaches, the fatigue, the palpitations, the anxiety, the bad periods, all of the things. It's never just one thing. So on my list of my pelvic pain initiators, endometriosis is drawn as a big one. Trauma is drawn as a big one. I also have other physical conditions, adenomyosis you've mentioned, which is kind of like endo, which is growing into the muscle of the uterus wall. Infection I've popped in there too. Surgery I've popped in there as well. And then there's like another level of things which sit behind those big ones. Adverse childhood experiences, we call them. Difficult upbringing, hypermobility, ADHD, autism, POTS, mood disturbance. And you need some of those things to push it down through the funnel to have pelvic pain. And I think it's really important to think this is not just one thing, which is why I say to people, in some ways, if you did have a laparoscopy and there's no endo found, that's interesting piece of information, but it doesn't really change much for me.
No, that's
it doesn't change the validity of the problem, and it doesn't change the management. So that's my pelvic pain initiators slide. And the next one is different because the pelvic pain perpetuators what keeps this going is different. Once you've gone through that funnel, what's going on is a different picture to me. And so about 9 o'clock the night before Cherie and I had to present to this group of politicians at Parliament House, I sent Cherie a text message and said, I'm going to draw it like one of those Newton's balls. So, you know, the perpetual motion, you grab one ball and you knock it through and it comes out the other side and it goes back and it goes back and it goes back and it goes back. And in my Newton's balls, I've got bad periods needs to be on there. That causes muscle spasm. Muscle spasm, of course, it's more complex than this, but it's nice to try and break it down. Muscle spasm in the pelvic floor causes bowel dysfunction. Bowels have got to come out through this big basket of pelvic floor. And those bad boys, once they're cranky, they don't want to let anything in or out. So bowel dysfunction is bad. Once you've got all of those things happening, you get stress. When you have stress, you get body symptoms, headache, dizzy, fatigue. Pain, so many things, whole body pain. So many symptoms. And from there you get life impact. And we touched on this last time. How am I going to go to work? What's my partner going to say? I'm missing another thing. I don't know what's going to be on the menu at the restaurant and if it's going to set my tummy off. And that bounces back and bounces back. So we've got a list of things that are the common things, which is bad menstrual cycles, muscle spasm, bowels, stress, and body symptoms. And to get pelvic pain better, regardless of what got it started, we've got to work on these things. And as you say, if you've had 10 years of this going on, this is not going to get better in 5 minutes. It's not going to get better in 2 weeks or a month. We've got to work out how we're going to stop, what are we going to do to treat some of these balls? I'm just interested in your thoughts on those. I know I've just given you a lot without much to look at.
I've got a really good image in my brain. I think I love the idea of the trigger ball, you know, the first ball that starts the swinging, you know. I guess the only thing I would say is that doesn't always need to be bad periods, you know. It could be the constipation and the bad periods could be the other way around, you know. And it could be the trauma that starts the Newton's cradle going. So I think we've got to think about what that is, and that's helpful. Having said that, some patients can't always identify what that is, although I'd argue as a GP, if you sit down and ask the story from the beginning, you know, when did you start your periods? You know, when is the first time you experienced pelvic pain? What did that feel like? How is the pain now in comparison to that? You know, so there are a few key questions that I think we can ask to kind of unlock what was that first perpetuator in the Newton's cradle there. So I think, you know, as much as, you know, we want GPs to understand and validate and all of that, sometimes we can only process the information we're getting, you know. So what patients can do in this scenario is actually start to think about your brilliant analogy there. And what was that thing that set off this cradle moving, you know? Can I go back far enough to think about that? Because actually I'd argue once you present something like that, in that sort of a story to a GP, it's very hard to just go, oh, well, I don't know what's going on and it must be 5 different things, because what you're telling them is the whole story, you know. So, yeah, I think it's a great analogy. I think you're absolutely right. You know, there is a sequence of events that lead to each other. And that's kind of the core of what perpetuates pelvic pain. But I think we've got to also acknowledge that there are other things that come flying in to that kind of cradle that's already swinging, and maybe swinging more violently or less violently. And then something comes in and it's, you know, it's like an earthquake, and then all your balls are going off all over the place. So, yeah.
And generally that's what happens, isn't it? By the time they've got in there, you've got all these balls everywhere. And I think if I can bring it together, what do either of you have any advice for those general practitioners who don't have these extended appointments or the confidence or background in this area? However, they're the GP that is available to these patients. Like, do you have any advice for practitioners
What teach our Evoca GPs and other GPs who want to join Evoca is that, you don't have to do it all in one bite, and buy yourself time also. So even in my first consult, if it's not in an endo clinic, I might have a patient who's booked a 15-minute appointment, right? So what can I do in that time? My job in that time is to listen to their story. I'm a big advocate for the golden minute. If you let the patient talk for a minute and don't say a thing, they will tell you what's wrong with them. And then you just need to add your few directed questions. And I almost always start with, when did you start your periods? What were they like? And if they have pain, my question will also be, when did you first experience pain in your pelvis, and was it like this? What's happened since then? Has it been like this every cycle? Has it changed? Has it become more continuous? Have you got different types of pain now? So you're starting to understand what that journey is, and then asking a few questions around the key bits, which are bowel, bladder, social, emotional, and also asking that difficult question. This might seem unrelated to you, but I need to ask you about a history of sexual violence, and
so it sounds like
the
first appointment is information gathering. And do
Absolutely.
you feel like that there's maybe pressure to do something or give something in that appointment when it's potentially you haven't got all the information and it may not be the best
Correct.
thing for the patient at that time?
Absolutely. And that's why I say that first appointment, you just want to hear them. You want to get all the information. And then I buy myself time by arranging the necessary investigations. So a urine test, a swab test, the right kind of scan. So not just a standard pelvic ultrasound. If I'm worried about endo, I'm going to talk to them about the right kind of scan. And then I send them off and I say, I don't have an answer for you now. I have some ideas, but ultimately I need the diagnostics along with your story to go along with that to help me make a picture of what's going on here. And in the meantime, if I don't have, we've all got those patients who go, I don't know, I haven't really thought about how many days of the week I get pain. I will say to them, go and do these tests, and in the next week, diarize what's happening, write a journal and put a red spot in there when you have pain and a number next to it. How bad is the pain? Something really simple that they can do, So I'm buying myself time to think more about it, to have the diagnostics and more information if I want. And then at the next appointment, that's when I'm going to start to be able to talk about what I think might be going on. And then we're going to talk a little bit about what that plan of care might look like, what those treatments might look like. And it might be something as simple as, look, when I examined you, your pelvic floor was really tight. There's this other stuff going on as well, but I really think that's a big component. So how about we start with that? And I'll see you after a session or two with the physio, and then we can talk about other options as well. Or if they need a contraceptive and they haven't got one, it's simple enough to start, for example, a pill, or, talk to them about a Mirena in that space. So your second appointment is results, pulling it together, and broadly forming a bit of a plan. Then your third appointment is kind of talking more about, okay, how are you going with the, what we've talked about, this concept of chronic pelvic pain, the initial treatments we've deployed to you, how are you finding those, and a lot of them will often feel, and I'm sure both of you have seen this, just being given, the information and validated, and actually a bit of education around, there's lots of things we need to tackle, but we're going to start with this bit first. And this person isn't giving up on me, keeps them on the journey. So your third appointment is really about checking in and then developing that plan further, I think. Okay, so we've done a bit of pelvic floor. Now we need to think about that other pain that you get that's like a nervy, shooty pain, or actually your bowels aren't great. So we need to look at that as well, So I think it's just this stepwise kind of layered approach that's very gentle, keeps them along for the journey with lots of checking in. So early when things aren't working and you can reverse a bit,
Sneha, amazing.
Amazing.
We're almost out of time. If you had 30 seconds to someone listening who has pelvic pain from today's discussion, from today's discussion, we've covered a lot of ground. Can you think of perhaps one thing that you'd like them to take away from today's discussion?
Yeah, I'm going to say it in one sentence, but it's actually 3 things.
Great, fine.
Love it.
All right, so you can have pelvic pain that is real and valid without endometriosis. You don't always need a laparoscopy. We can treat you anyway.
Yes.
And if you give all your information to the GP, they should be able to help you, So don't give up. And if I don't like saying this, but if you're not being heard, find someone who will hear you.
Dr. Sneha Wadhwani, Cherie Noble, what a wonderful discussion. Thank you so much for your generosity and your time.
Thank you.
You both give me goosebumps. Such a pleasure to get to work with you. Look forward to seeing you soon, and look forward to our listeners as we continue this podcast, where we will continue to break down the different bits of the puzzle that we've talked about today. That's where we're heading next. Dr. Wadhwani, thank you so much. Cherie, thank you so much.
Pleasure.
See you soon.
Bye, Sneha.
Bye.
Bye. Thank you.